what a pain management doctor does.
Absolutely. So pain management is a very broad field. When we talk about pain management, we could essentially be talking about any physician who takes care of patients that are hurting. To that end, though, we kind of need to specify, because that could include pain that is relatively acute or short-lived in nature. It could also include pain that is more of a chronic nature, which extends for some period of time beyond an original injury or an original insult or anything like that. So when we talk about pain management physicians, generally we're discussing doctors who have had extra special training in treating patients who hurt every day and have hurt every day for quite a long while.
Gotcha. And what is the difference between acute pain and chronic pain, and is there different causes for each of them?
Yeah, it's a good question. I like to think of it more as a continuum. So just for our listeners to understand, acute meaning more short-lived and chronic meaning more long-term. Generally in the world of pain management, we consider acute pain to be anything inside 3 months. So let's say, for instance, if a patient has had a surgery and they have continued pain, let's say at an incision site or following an injury, the natural course of the body is to heal itself, and the pain should generally resolve, we say, depending on the insult, within 3 months. If the pain persists beyond that, then we start to discuss it in terms of chronic pain. And that's important because treatments for chronic pain differ widely from treatments for acute pain.
Gotcha. Health Fields and get your questions answered. And every Wednesday evening at 5:30, we are live on Facebook. You can find more information about our show on our website, doctalklive.com, and you can also find information on all social media platforms, including YouTube, Facebook, Twitter, and Instagram. And you can also listen to our podcast on iTunes, Spotify, and iHeartRadio. And today we have a very interesting topic lined up. My name is Dr. Sri Venkatraman. I'm going to be the host, and today we are going to be talking about pain management. And we have two experts in the studio with me today. One is a pain doctor, another is a foot and pain specialist. So we're going to be talking two different things, foot and ankle pain, and general pain doctor is here. So I have Dr. John Baca and Dr. Brian A. Duddle with me here. Welcome to the show. Thank you very much for volunteering your time to be with us. And Dr. Baca and Dr. A. Duddle, please let's get started by introducing yourself to our listeners.
Absolutely, yeah. Well, first, thank you so much for having me. It's a pleasure to be here. I'm happy to be discussing something that's very interesting and near and dear to my heart, which is pain management. My name is Dr. Brian A. Duddle. I am double board certified in anesthesiology and pain management. I'm in practice in Plano, Texas, my hometown where I grew up, and I know that I have 3 adorable little nieces listening right now, Kinsey, Kirby, and Caitlin, so I wanted to say hi to them. Yeah, I'm happy to get into it and discuss any sort of pain management questions that you guys might have.
All right, Dr. John Baca.
Yes, thank you so much for having us. My name is Dr. John Baca. I'm a reconstructive foot and ankle surgeon. I practice in Plano, Texas as well. I'm also a hometown boy. I grew up a small town outside of Fort Worth. I've been gone for a long time for training on the East Coast and the Midwest, but ended up back here and been practicing in the area for the past 6 years.
All right, welcome. It's great to have you guys here today at the show. I'm going to call you Dr. A, the pain specialist doctor.
No
Okay, so
it's safer that way.
All right, I don't want to be sick.
Right.
Thanks, Dr. A. To start off our show, why don't you explain to our listeners what a pain management doctor does?
Absolutely. So pain management is a very broad field. When we talk about pain management, we could essentially be talking about any physician who takes care of patients that are hurting. To that end, though, we kind of need to specify, because that could include pain that is relatively acute or short-lived in nature. It could also include pain that is more of a chronic nature, which extends for some period of time beyond an original injury or an original insult or anything like that. So when we talk about pain management physicians, generally we're discussing doctors who have had extra special training in treating patients who hurt every day and have hurt every day for quite a long while.
Gotcha. And what is the difference between acute pain and chronic pain, and is there different causes for each of them?
Yeah, it's a good question. I like to think of it more as a continuum. So just for our listeners to understand, acute meaning more short-lived and chronic meaning more long-term. Generally, in the world of pain management, we consider acute pain to be anything inside 3 months. So let's say, for instance, if a patient has had a surgery and they have continued pain, let's say at an incision site or following an injury, the natural course of the body is to heal itself, and the pain should generally resolve, we say, depending on the insult, within 3 months. If the pain persists beyond that, then we start to discuss it in terms of chronic pain. And that's important because treatments for chronic pain differ widely from treatments for acute pain.
Gotcha. And what does it involve? I mean, how do you get to be a pain doctor? I just want to ask,
Sure.
do you have to go through some special trainings and stuff?
Sure, there is. Like any physician who specializes, there's kind of a little pipeline, a road to being a pain physician. It's important to note that, again, as I said at the outset, just about any physician can treat pain. So surgeons who operate, such as Dr. Baca here, they kind of help to treat the pain during that acute post-surgical period. But in order to be specialized as a pain management physician, generally you will have done medical school, of course, and then a residency, and then often a fellowship year, which is an extra year of training specializing in pain management. The most common pathways to that can be what I am, which is an anesthesiologist. The other common pathways to becoming a pain specialist include neurologists, as well as physical medicine, PM&R doctors. So all of those fields can go on to specialize in pain management.
Gotcha. Dr. Baca, so you, just to get you on board with our pain specialist, so you deal with foot and ankle pain, I guess, so is that your area of specialty?
Yes.
Can you tell
Yes.
me what do you do?
So I am a surgeon by trade. So I deal with everything from traumatic accidents and falls to infections and wounds, to sprains and things like heel pain and tendonitis. Dr. A is certainly right. I typically deal with more acute injuries, acute pain, acute accidents, but there's a lot of overlap between us often.
Okay.
In patients that sometimes have surgery or revision surgery, and often either the surgery itself is not enough to resolve their pain, or sometimes, unfortunately, some people get into something called complex regional pain syndrome, which he can talk a little bit about, but that happens sometimes after surgery as well.
Okay.
And that deals more into a nerve type, sympathetic type of pain, which is chronic in nature as well. So we do have lots of overlap between us, even though I typically deal with acute pain or musculoskeletal pain. Often some conditions which seem musculoskeletal, such as, chronic heel pain, sometimes is truly coming from somewhere else, like the low back or nerves in general.
Mhm. So you kind of work with Dr. A in coordinating the patient care, I guess.
Yeah,
right?
I mean, typically I'm trying to rule out acute causes for the pain or acute musculoskeletal issues by lots of things like stretching or physical therapy. Often we get advanced imaging like MRI or CT scans. But if I can't find an acute cause for the pain or don't think I can do something to directly benefit the patient right away,
Uh-huh.
often I'm referring to a pain management specialist like Dr. A to figure out where it's coming from and why. And often, it's not related to musculoskeletal stuff, even though it does present like that. But there are subtle signs sometimes in the way the pain presents and when it happens and what exacerbates it, that can kind of lead us down the road to suspect there's another cause for it. But traditionally, I'm usually managing acute pain.
So-
I think I might jump in on that, Dr.
Yeah.
Baca. Just to point out that when we talk about pain in general, pain serves a purpose. The body has a
Absolutely.
natural response to
Yep.
pain, and it's designed to prevent tissue injury, prevent further injury or damage, morbidity, mortality to the body. So when Dr. Baca speaks to acute pain, let's say you're walking along and you stub your toe. Everybody has that experience, and it hurts. Well, that's or even a more classic example. You put your hand on a hot stove. The pain is there to tell you to remove your hand so that you don't have further tissue injury. The differentiation between that pain or a pain that becomes more chronic in nature or more lasting might be defined as a maladaptive type pain. In other words, the pain is not serving any further purpose at that point. So for a patient that has chronic pain, our goals are often to manage that pain, to preserve functionality, so that they can go on with their life and do the things that are important to them and that they need to do, given that that pain is no longer serving an important role in their body.
Okay. On that point, Dr. A, what are the treatment options? How is the pain treated? I guess it depends on different body parts, organs, and stuff. So can you tell our listeners a little bit about it?
Sure. I think the treatment of chronic pain is, we think about it, kind of the buzzword here is multimodal. So what we want to imagine is that for whatever the particular condition is, we're not just going to offer one singular treatment. All the studies at this point indicate that the best way to optimize for long-term functionality and long-term pain control is to combine a set of methodologies that can include things like medications, rehabilitation, physical therapy, surgeries if indicated, or where my specialty really has made the most strides is in interventions, injections, and procedures, things of that nature. So that in the long term, we can optimize for functionality, as I said.
Gotcha. So is injections like an outpatient? Do the patients need to come to your office, or is it done in the hospital? Can you tell us a little bit about it?
Absolutely, yeah. So when I say injections, there's a variety of different injections that are available, procedures that are available. I do many of my procedures in my office. I do them with a patient more or less awake and some numbing medicine, and they do fantastic. They're in and out of my door inside 30 minutes usually, depending on what we're treating. I should clarify, most commonly, some of the most common forms of chronic pain are low back pain or neck pain, so spinal pain, and that's what I deal with a lot of. And I'm sure many of our listeners will be aware that there are quite a few patients out there in the world who have back pain.
Yes, back pain is very common.
It's very common, and so there's a lot of interesting methodologies and injections and procedures that we can do that keep people functional, and in some situations are able to help them avoid a surgery if that's what their goals are.
That's nice. Going back to Dr. Baca, what is the chronic heel pain that a lot of people experience, and I'm sure you see that quite often in your clinic?
Yes, that's probably the most common complaint I have with people coming in, especially as the temperatures are getting warmer, people are getting more active, everyone's getting vaccinated, we're getting out to do more stuff. Typically, it's something we call plantar fasciitis, which is just a fancy way of describing heel pain. The plantar fascia is the name of a ligament on the bottom of your foot. You have the same type of ligament in your palm that's called the palmar fascia. Both of those are just support structures. They don't stretch, they don't move, they're just there like a ropey tissue to connect bone together. And the calf muscle and Achilles attached to the back of the heel, when that calf muscle gets really tight, puts a lot of pressure on the back of the heel, and it affects that ligament on the bottom, which isn't elastic, and so that's what causes the pain. And so most people describe it as a soreness or dull sensation kind of on the bottom of their foot. And just like Dr. A was talking about multimodal approaches, that's exactly what we take for heel pain. It involves sometimes medicine like steroids or anti-inflammatories to help decrease the acute pain, ice to help take off some of the acute pain and inflammation as well. But we also involve a lot of calf stretching and outpatient physical therapy and other modalities like night splints and stuff like that to help relieve that pain. But it is a long-term process to relieve that pain on the bottom of the foot, because there's no direct intervention to the bottom. We can't technically stretch that ligament out without surgery. So we try to avoid long-term chronic pain to the heel with these modalities, because long-term studies tell us if you've had pain in the heel longer than 6 months, those basic, cheap, easy things I'm talking about are often ineffective at relieving that pain anywhere remotely quickly.
So you have to have surgery done for that?
Sometimes you have to have surgery. Sometimes you have to dive into other things like shockwave or EPAT therapy, which can be therapeutic for patients. But yeah, you're getting into either surgical or expensive treatments sometimes, or advanced things like that, PRP injections sometimes. But you're looking at invasive treatments or expensive treatments outside of those basic things if it goes on too long. But that goes on for almost any pain in the foot and ankle. I see a lot of people with tendonitis, whether it's tendonitis on the outside of the ankle or inside of the foot, or Achilles tendonitis, any kind of chronic inflammation you have anywhere in your body isn't a good thing. And the longer that chronic inflammation sits around, it can do damage to your native tissue. And that can cause, sometimes surgical problems like Achilles ruptures, which are often acute on chronic injuries, especially in day-to-day, what we call weekend warriors, like guys like myself that work all week and then go and think we can play football on the weekend with our buddies. And then you tear an Achilles playing basketball or something. Well, that's what it happens. It's usually an acute force or acute amount of trauma that goes through a structure that's been damaged chronically by inflammation, and that can cause major issues.
Okay, gotcha. So, the next thing is the ankle sprain that you see a lot, right? So, what do you think? Is it bad or good?
Well, it's certainly not good. I think a lot of people, myself included, when I was younger, I'd have ankle sprains all the time playing sports, and we all did, doing things as younger adults. Typically, if you sprain your ankle and you can put weight on it immediately, it's sore, it's swollen, but you can walk on it. Those aren't typically major issues. But I think what's important is to make sure you get that evaluated relatively quickly, because I do see a lot of people with tendon tears or sometimes subtle fractures that maybe not hurt enough to keep the patient off their foot, so they keep walking on it, and they come see me, months after an initial injury, and we get imaging, and it turns out they did do something major. So typically they're not major injuries. You can walk on them right away. Sometimes we put people in restrictive boots for a couple of weeks, followed by some bracing and physical therapy and early rehab to get them going. But I think that is a thing I see a lot of, but it's often either not diagnosed or misdiagnosed early. So I think it is important to go see a specialist relatively soon, just to make sure you didn't do anything major, number one, and number two, that they get you on an early schedule of rehab, so you don't end up with, like we said, chronic pain or chronic instability there long term.
Dr. A, do you see any chronic ankle pain? Is there any pain management treatment options?
Certainly. I think maybe one of the areas where Dr. Baca's practice and mine overlap quite a bit is a particular condition that's kind of unique to my specialty. It's known as complex regional pain syndrome, or CRPS, and this is a constellation of symptoms that affects an extremity. It certainly can be the feet, it can also be the arm or the hand, but it's again another maladaptive pain syndrome wherein usually there's some sort of inciting injury. It could have been an accident, it could have been a surgery, something like that, but over time the extremity becomes swollen and discolored and angrily inflamed, very painful, and these are patients that we want to intervene in quickly, because the goal is, as is often my goal, is to maintain functionality and preserve function of that extremity. So there's some spinal injections that I can do called sympathetic nerve blocks that help to kind of break the signals from the extremity as they're traveling up to the brain.
Okay.
If that's helpful, then that's an option for the patient. And then some other things as well that are more advanced if it comes to that. But certainly that's one component of it.
There's an option after Dr. Baca does all his things.
It's important that whatever specialist, any other musculoskeletal specialist, finds those patients early and identifies them early. I may not be able to treat everything, involving CRPS, but I have to catch it early and refer them on to someone else quickly. The sooner we get to them, the easier it is to treat them long term.
The outcomes are much better.
Yeah.
The other common thing, Dr. Baca, is the bunions. You see them quite often, and that's a common problem for everybody.
I do.
What is your take on that, and what is your advice to the patients?
Bunions they're a genetic deformity. We used to think that shoe gear caused them. That's been proven not to be the case. Lots of people have bunions. Doesn't always mean you need to have surgery for them. I typically don't operate on bunions unless they're painful or limiting to activities or certain shoe gear. I do see a lot of professional females who have to wear heels or dress shoes to work. The bunions may not bother them in sandals or tennis shoes, but that we can't all wear tennis shoes to work every day like me. So sometimes they do have to be fixed. Unfortunately, there's not a lot of conservative treatment options for them. Braces and splints haven't been proven to be successful in long-term studies. So really it's shoe gear modifications and ice and kind of anti-inflammatories unless it gets to the point that it's really affecting your activities. It keeps me from running. It keeps me from working out. It keeps me from walking for long periods of time. That's what I enjoy doing. Then we talk about surgery for them. But really, surgery is the only corrective thing for bunions. But again, that's not to say everyone that has bunions needs surgery, only if they are painful. We certainly don't do cosmetic foot surgery. There are a multitude of professional athletes that have horrible bunions, but they are non-painful, so they play their entire professional career and never have anything done.
Okay, that's not. So what about wearing special type of shoes and stuff?
Yeah,
does that
typically-
play a role?
Yeah, it does. You typically are looking for shoes that don't put pressure on the inside of the foot. So if it's flats, you want to find stuff with leather that's stretchable.
Okay.
If it's activity shoes or running shoes, you want to find shoes that have mesh on the inside, so there's give and there's not anything tight pressing on the inside of the foot. There are lots of different brands of tennis shoes and running shoes and workout shoes that most people can find something comfortable, unless, again, it gets to the point where, for every particular patient, there's a breaking point where I think shoe gear modification sometimes for some people can only go so far,
Yeah.
and then eventually surgery has to be discussed.
I want to have a question for both of you, since both of you deal with pain, and Dr. A is a pain specialist, and you deal with foot and ankle pain. What is your take on opioids that's being used, and that's kind of a little scary now. We see things about. So, Dr.
Yeah.
A, can you start off? And
No, it's an excellent question. It is quite timely, and certainly anyone who has not been living under a rock for the past 5 years has heard about the opioid epidemic.
Yes.
So that's something that my specialty is kind of right on the cutting edge of. I believe that opioids in general, and I believe that the evidence has now supported this, have a very limited role in managing chronic pain.
Okay.
And that is to say, I should be more specific, chronic non-malignant pain.
Okay.
So there's a variety of different chronic pain syndromes. If somebody has end-stage cancer, then they have quite a bit of chronic pain. In that situation, opioids play a good role, I think. The evidence is now very clear, though, that if we take a patient who, let's say, has low back pain and they've had a surgery, and unfortunately they continue to have pain after that surgery, and then we start them on chronic opioid therapy, we've taken one problem and made it into two problems.
Oh, okay.
Because ultimately what happens is these long-term data are now very clear that those patients, their reported pain scores years and years down the road aren't any better than when they first started, but they have the additional problem of having had developed tolerance and potentially in some cases even addiction. So my view on this is that opioids can serve a limited role, perhaps in a short course. Now, the other thing is, to get back to what we were discussing at the beginning, acute pain is a different scenario.
Yeah.
So acutely after a surgery, a patient might be given a short course of opioid therapy to get them over that acute post-surgical pain. However, we have to be very careful that we don't extend that beyond a certain point, which can vary from patient to patient. Now, let me just step back from that and observe that we have an entire demographic of people in the world now who have been placed on these medications and are on them long term. And we have to be responsible in the way that we treat these patients. And so in my clinic, I take all of the necessary precautions, and I have close follow-up with every patient who is on chronic opioid therapy to ensure that the medications are being responsibly used, that they aren't being diverted into another source, and that also that the therapy is effective. Because at the end of the day, what we're really trying to do is effectively manage pain. If I end up with a patient who's on chronic opioids who tells me that they continually need higher and higher dosages, that's telling me that that's not working.
Yeah, that's right.
And we need to reevaluate and come up with a better strategy to manage the pain. And those can be challenging conversations sometimes, but I think they're necessary, and I think it's
at this day and age with the
Yeah.
opioid pandemic.
Yeah,
yes,
because-
it's crazy.
because we now have, and the exact numbers will escape me, but over 500,000 deaths in this country due to the chronic opioid overdose.
Yeah.
And very often that very sad pathway, involves patients who have been placed on prescription opioids, and they're then taken off and seek those medications through other less safe channels.
Yeah, now
So-
that you said there are a lot of other ways like injections and stuff available.
Absolutely, that multimodal approach that we were
Multimodal
talking
approach that you were
about.
talking about earlier and stuff.
Yeah,
So
what do you think, Dr. Baca?
Yeah, I mean, I agree with all of that. There's certainly a role for opioids in my practice for traumatic injuries. Often patients have surgery and their chronic pain is made acutely worse by surgery for a short period of time. But I have to be very diligent and careful when I dose those. We don't keep people on them for very long.
yes,
We don't keep them on high doses for very long. We have to taper them down very quickly. And we use multiple medications in addition to the opioids to lessen the use of opioids. We use nerve blocks in surgery to help decrease acute postoperative pain. We keep people immobile for certain periods of time to help lower their pain use. So I certainly use them, and I think they're appropriate in certain conditions. But it's up to the clinician and the patient to diligently
them off.
watch the usage, yes, and make sure that we are quickly transitioning away from that so that doesn't become a chronic problem.
Just a few questions, Dr. A. To get to see you, do I have to have the patients or the listeners or anybody need to have a referral, or they can make an appointment if they have pain?
Nope, just call us up. We'd be happy to see anyone.
Okay. And then Dr. Baca to see you. I mean,
Only certain insurances require a referral. It's usually HMOs.
Okay.
But yes, as long as we have referral for those, we're happy to see everybody for any condition regarding foot and ankle.
for an ankle,
Yes.
they can
Absolutely.
make the appointment. They're covered by insurance, most
Yes,
insurances.
yes,
All the
yes.
procedures that you talked about
Yes.
and stuff. So
Yes, everything we
that's
do,
good to
and
know. People are worried.
we try to be transparent, even with the patients when they come into the office regarding everything that what's covered, what's not covered. Here's the cost,
Yeah.
etc.
That's right.
I'll just let you know, you can find me in my practice. As I said, my office is in Plano. You can find me on the web at www.painsolutionsTX.com.
InSolutionTX.com.
And I also am in Plano as well. Our office website is totalfootandankletx.com.
That's nice, very nice. And we had a very interesting discussion today talking about pain, and pain is something everybody has, and Dr. A was giving us different modalities of treating and foot and ankle stuff. One quick question, Dr. Baca, whenever you have a foot and ankle injury, do I have to rush to the ER, or can I wait and do some things that I can do at home and then get to see you guys?
That's a good question. I think, emergency things to be seen in the ER for are, open injuries, obviously, lots of bleeding, inability to put weight on a lower extremity. Those are things that need to be emergently checked out. But often, even when you're seen in the emergency room, they will temporarily stabilize the patient and then refer them to my office. So most injuries, sprains, bumps, cuts, that kind of stuff can be seen in the office.
Okay. Thank you very much for your time today. We had a great discussion. And listeners, this is Dr. Shree signing off. Wait for another week for a great episode next Wednesday. Thank you.